West Coast sickle cell disease, has been for some time. Got a Lifetime Achievement Award from his alma mater, Creighton University, which recognized that he had established, led, maintained, and grown one of only 10 continuously funded sickle centers in the disease. Those of us who have to give these patients transfusions are often wondering if we're buying time, and I expect to be thoroughly confused once Dr. Johnson is done. Although I have to say, having heard him speak, I usually I'm a lot more clued in afterwards, but it's a real honor for us to have. We had the East Coast Dean of Sickle Cell, now we've got the West Coast, and the two of your careers have essentially overlapped to a large degree. So thank you, Dr. Johnson.
Thank you. Now, Jim took in. We had a few difficulties with, all right, how do I get full screen on this?
Up to view, full screen.
View? Okay. So I can't read these little 4 fonts anymore.
It's actually
More now.
Full screen. There we go. Okay. So, all right. Now I got to find the start. Here we go. Okay, so I mean, it's at the same time a great honor to be here to speak about sickle cell disease and have in the audience the giants in this field. It's a sad time because one of our esteemed leaders is stepping down, but I'm not worried because I have his cell phone number. So I'll still be able to call him when I have a question, which I have done on occasion, and he's been very helpful. So today I want to talk about transfusion consequences and its consequences. And I started this title, The Good, the Bad, and then I couldn't think, okay, what word am I going to put in at the end? The awful? I didn't want to put in the ugly because then everybody would be thinking about Clint Eastwood movies. So, and I have no conflicts of interest or any of that stuff to proclaim. So, like every therapy we use for whatever disease, it has its good points and it has its bad points. So transfusion generally is thought to be very beneficial. I'm going to unfortunately cast some doubt on that today. So it increases the oxygen carrying capacity by improving the number of hemoglobin molecules in the circulation, so there are more trucks to carry the oxygen around. It is believed that reducing the number of sickle cells, the percentage of sickle cells in the sample, improves the overall cell deformability and blood viscosity. And unfortunately, I think that is not quite as true as we think. And overall, the blood flow and the subsequent oxygen delivery to the tissue reflect the balance between the blood viscosity and the compensatory alterations in vascular resistance that control flow. And we'll come to this later on in greater detail. That's going to be the final portion of this presentation. So the benefits are well known for transfusion. They're listed here on this slide. We'll talk about them in a little greater detail. So there are two risks. And again, I don't want to say minor risks because these are clinically significant issues. But the transmission of viral infection, the alloimmunization, and the iron overload are continuing clinical problems today. The major risk, I want to differentiate these because these are the ones that are potentially life-threatening. Hemolytic transfusion reactions, either acute or delayed, and of course the hyperviscosity syndrome, which is the consequence of the addition of normal red cells to sickle cells, and there are sometimes things that happen that are unexpected. So it's well known that transfusion therapy is effective in the primary and secondary prevention of stroke in children with sickle cell disease by reducing the subsequent events by 90%. It reverts the TCD velocity to normal, back to normal, in a large number of such patients. However, there is an incidence of new stroke after stopping transfusion, and we don't know how long we have to continue this. But recent developments suggest that even though we are reducing overt CNS disease, strokes that we can see by physical examination, there is continuing development of silent infarcts in patients who are receiving transfusion. And this is I think, been alluded to by previous speakers, that sickle phasal occlusion events may continue even though patients have been extensively transfused for long periods of time. Transfusion benefits children because it reduces the hospitalization rate for the acute chest syndrome significantly. Here the patients on chronic transfusion, here the patients receiving episodic or standard indications for transfusion. And you see the numbers, and they're fairly obvious. There's a statistically significant decrease in hospitalization rate for acute chest syndrome. There's a decrease in hospital rate for pain. Didn't achieve statistical significance, but a pretty big difference. Maybe a bigger study or a longer time would have helped. But in addition, that there is a statistically significant increase in growth velocity, both for weight and for height, in children on transfusion compared to those who are on episodic transfusion, and compared to both concurrent and historical control groups, one from the cooperative study of sickle cell disease here on the far right, and one from the HUG Kids, the early study of hydroxyurea in children. So there are clear benefits. I can't go any further without alluding to the seminal paper by James Ekman and colleagues some 20 years ago. Has it been that long? In which they were the first to show that transfusion therapy, either simple or exchange transfusion, was life-saving in patients who had acute chest syndrome with pulmonary failure and multi-organ failure, in which 16 of the 17 episodes patients survived, which was maybe 30% prior to 30% survival prior to that. I mean, this was a paper that really advanced our thinking in the utilization of transfusion in acute life-threatening situations. Transfusion has been used for preparation of surgery, and what we know is that exchange transfusion versus simple transfusion, there really isn't any difference, other than exchange transfusion has more alloimmunization as a consequence because of the bigger number of units exposed. The jury is still out on whether or which surgery patients need transfusion and which do not. And I don't know when we're going to be able to answer that. Obviously, if the patient is acutely anemic because of an aplastic crisis or other event causing anemia, transfusion can be very helpful. Remembering that, and this has been shown in normals as well as in sickle cell patients, that hematocrits between 30 and 35% show an increase in venous oxygen tension, implying improved oxygen delivery to the tissues. But once you go above 35%, then there is a decrease in venous oxygen tension, implying that blood flow has been impaired at the higher hematocrit. And again, this is an issue we're going to discuss in a little greater detail in several slides down the road. So I put this slide in for you to look at, to give you some perspective on the risk of transfusion, because I know in dealing with sickle cell patients and with other patients in hematology, there's a wide concept of the dangers, the risk of transfusion, some of it unjustified. But just to show you some data compared to some other risk, interestingly, death from medical error, 1 in 1,000. That kind of got my attention. This is transfusion-associated cardiac overload. It used to be called CHF. I don't know why they keep inventing new acronyms for things. Transfusion-related acute lung injury, that's an immune reaction. But notice, viral transmission, this is today's data. Viral transmission. Hepatitis B, maybe 1 in 600,000 units. I mean, the screening is so good that we're approaching the limits of detection for these viruses. Hepatitis C and HIV more than or less than 1 in 1.2 million units. They're not going to be able to improve on those figures. They're at the limit of detection now. Everybody's afraid of getting struck by lightning, but I don't think we should really stay awake worrying about that. Its frequency is very, very low. However, everybody drives, nobody worries about it, but driving has a relatively substantial risk of 1 in 10,000. So, in our studies, relative to viral transmission in patients with sickle cell disease. So in our studies that were published in the mid-'80s, this reflected bloods drawn beginning in 1976. So we followed 100 patients with sickle cell anemia and 25 patients with sickle C disease over time to elucidate what kind of liver problems they were having. And much to my chagrin, I found that California had the world's highest frequency of antibody positivity to hepatitis C. We had 3% of our patients with sickle cell anemia had chronic active hepatitis B, 64% and 44% of the sickle C patients in our patient population had antibodies to hepatitis C, compared to data from other sites across the world. Some individuals, Nigeria has a very high hepatitis B population, but other parts of the United States, the hepatitis C was in the 20 to 25% range, much lower than what we saw. Now remember, these were patients who had received transfusions long before the introduction of the first screening test for hepatitis C in 1993. And so screening for hepatitis C was based on history and transaminitis indications. So it was the frequency of hepatitis C transmission in those days was probably 1 in 3,000 units. So these are risks that are still present, but they're extremely low at the present time. So we don't worry about them as much as we used to. Still, the patients, especially older patients, you have to screen them for that because you need to know whether they're positive and whether they need antiretroviral or antiviral therapy. So the next risk is alloimmunization because of the mismatch, especially in the C, D, E, and K regions between the donor population and the recipient population, which is primarily Afro-American. Frequencies of anywhere between 7 and 47% have been reported, and this is related to the age of the patient. The younger you are at the first transfusion, the more likely you are to develop antibodies, how many, and the extent of antigen matching by the blood bank. These all correlate with the frequency of alloimmunization. So, matching for C, E, and K have been widely recommended to reduce the degree of alloimmunization in patients receiving chronic transfusion, and has been effective in one prospective study in reducing the frequency from 3% to 0.5%. Despite such data, a survey of nearly 1,200 blood banks in the United States revealed that 63% only tested for ABO and RH, or D. Only 10% did extended phenotyping, but they didn't match the donor units, and only 28% did extended phenotyping and donor matching to reduce the alloimmunization. In an unfortunate publication, or at least a very disappointing publication just published in Blood, an institution using a minority donor pool, thinking they would get units that are more likely to be cross-match compatible, Donor matching for the four most common antigens that lead to alloimmunization. Over 50% of the patients on chronic transfusion developed alloimmunization, including 15% of those on episodic transfusion. In addition, half of those on the chronic transfusion also developed autoantibodies. So even using a ethnicity-matched donor pool and extended phenotype matching still leads to a high rate of alloimmunization. So this is a problem that needs a lot more work. Iron overload can occur in these patients due to transfusion therapy or inappropriate iron therapy during the patient's lifetime. It leads to cirrhosis. It increases the risk of hepatocellular carcinoma and may accelerate the damage of chronic hepatitis C in this patient population, amongst other things. So again, this is something that I was going to talk about ferritin, but I'm not today. So, this is another issue where we have to be careful about iron overload in our patients on chronic transfusion, giving the appropriate therapy to prevent and ameliorate iron overload to prevent these long-term complications. Now, the life-threatening risk in this patient population, acute hemolytic transfusion reaction. All of us who treat patients are familiar with this. This is an ABO mismatch problem, usually due to technical error, human error, and may occur in as many as 11% of transfusions. Usually apparent within minutes to hours, and shows up as fever, chills, tachycardia, and hopefully not too much circulatory stress, and has a number of complications, especially relevant to the patient with sickle cell disease, including the acute chest syndrome, renal disease, etc. Yeah. We just had last week a delayed hemolytic transfusion reaction. This is a life-threatening anemia following transfusion and has a characteristic clinical syndrome which we described some time ago. So there's hemolysis of the donor erythrocytes following the transfusion and suppression of autologous red cell production, reticulocytopenia, so that the anemia gets very severe. Antibodies may not be easily detected, especially if all the donor red cells antibody-coated have been destroyed and the antibody has not made it back into the serum at the time you test the patient. So we had a case just last week. Patient got 1 unit, was sent home, comes back 4 days later with new pain, and the hemoglobin was again lower than when she left. And these milder episodes are frequently under-recognized. In addition to the reticulocytopenia that contributes to the anemia, patients may have autohemolysis because of bystander hemolysis in the generation of large amounts of immune complexes. And this is related to the fact that the dense sickle red cells have difficulty in regulating the complement membrane attack complex. So in these situations, you have patients who have worsening anemia. You give a transfusion, and the anemia doesn't get better, but actually gets worse. The hemoglobin keeps falling despite periodic additional transfusions. So therapeutically, you're up against the creek because you have to stop transfusion, give IVIG, high-dose steroids, and hope that the reaction stops so that the patient can recover. What I really want to talk about today is my area of interest, which is in the rheology of the blood. And this is the hyperviscosity syndrome. So whole blood viscosity is a function of the number of red cells, as well as their physical characteristics. The physical characteristics of the sickle cell differ from the physical characteristics of the normal erythrocyte. And thirdly, there's an effect of the plasma proteins, fibrinogen and immunoglobulins, that all play a role in the whole blood viscosity. It's important to come in the next slide. So, in sickle cell disease, hemoglobin S gelation and the number of dense cells predominate in the measurement or effect on whole blood viscosity, especially when the cells are deoxygenated. So the hyperviscosity syndrome is another post-transfusion acute event characterized by a sudden increase in the blood pressure. I'll show you why the blood pressure has to go up, followed by altered mental status, headache, seizures, congestive heart failure, cerebral hemorrhage, and can be fatal. And the reason is, in the cerebral circulation, if the viscosity, as the blood vessels get smaller and smaller, the apparent viscosity goes up. So under conditions of low flow and high oxygen extraction, the sickle cells, because they're partially polymerized, the blood viscosity can get very high and flow can actually stop. The phenomenon Dr. Hebel showed in the test tube, where the cells don't layer when you tilt the tube, is because they're all stuck together and their viscosity is extremely high, in what we call the Furius-Lindquist effect. As the diameter of the vessel gets smaller and smaller, the viscosity may become high enough that flow essentially stops. The blood is still liquid, but it's not moving, and therefore oxygen delivery past that point is going to be significantly impaired. And that's what we think happens in these patients with the hyperviscosity syndrome. So what has it all got to do with viscosity? Well, let me just start with what we call the flow equation, because hardly any of us can pronounce Poussaye. So the flow equation shows that flow is relative to the difference, the pressure drop across the length of a tube or blood vessel. Obviously, we do these experiments in tubes because they don't let us use live subjects for rheology experiments. So the change in pressure across the length of the tube times pi, a constant, and notice the radius to the fourth power. So the radius has a huge impact on flow. In sickle cell disease, the blood vessels are already near maximally dilated. So the effect of the radius is already at its maximum. Divided by 8 constant times the viscosity times the length of the tube. So if you think about this, the things that are variable, really, the radius to the fourth power, that's pretty much fixed. The pressure is not. Pi is fixed. The length is fixed. 8's fixed. So the only two things that can change are the pressure and the viscosity. So if you hold the pressure constant and raise the viscosity, flow goes down. So if you raise the viscosity, you have to increase the pressure in order to keep flow going. So that's why in the hyperviscosity syndrome, an elevation of the blood pressure is part of that syndrome. So pressure and viscosity are the main determinants then of flow in the microcirculation in sickle cell disease. The other effect is illustrated here. So curve A is the oxygen saturation dissociation curve for normal cells with a P50, that partial pressure of oxygen at which half the hemoglobin is saturated is the way we just talk about this. P50 is 27 plus or minus 3 normally. Curve B is sickle cell anemia. This is 40 patients we did, and the P50 is 39 plus or minus 5. So sickle cells have a much right-shifted oxygen saturation curve. And what that means is that at any given oxygen tension, sickle cells are less saturated than normal cells. Consequently, if you mix normal cells and sickle cells, because the normal cells have a higher oxygen affinity, they may actually draw steal oxygen from the sickle cells, further desaturating the sickle cells and promoting polymerization. Again, an effect that may occur in the post-transfusion effect. I don't think anybody really cares that if you deoxygenate the cells, they get more rigid. And these are experiments we did in England. If you add water to the cells, you make them more flexible. So if you look at, oh dear, this is too dark. If you look at the individual components, and you've seen and heard about density separation of sickle erythrocytes. So the most dense cells, layer 4, primarily irreversibly sickle cells. These cells this is a membrane measurement of membrane viscosity, and you can see it's almost twice as high as the other fractions in this experiment. So the calculated surface viscosity is 21 dynes per inverse second per centimeter, which is substantially more than the other cells. So the dense cells are the ones that have this abnormal impact, or deoxygenated cells will have an extra impact on the viscosity and flow of mixtures of A and S cells. You can skip that one. So everybody has seen this. I think this is a famous experiment by Jan and Gene Smith and their colleagues, in which they showed that as you transfuse patients, as you increase the hematocrit, once you get to around 35, the oxygen delivery to the tissues is impaired, presumably because of poor flow. Now, these experiments were done in mixtures of red cells and buffer, so that the component contributing to whole blood viscosity from this slide won't show. I can describe what it's supposed to show. So, in these experiments, the component of plasma that participates in the whole blood viscosity is not present. What this slide shows is, if you look at, these are normal cells, if you look at the viscosity at low shear, which is most compatible with what goes on in the microcirculation, versus high shear, which is what mostly goes on in the arterial circulation, blood is more viscous at low shear, normal cells at low shear, than at high shear, because blood is a non-Newtonian substance. If you take the cells and put them in buffer, as opposed to cells in plasma, the viscosity at low shear is twice as much as the viscosity for cells just in buffer, and that's because of the effect of the fibrinogen and immunoglobulin. So we did a series of experiments, which unfortunately the graph is not going to show, but we did a series of experiments. Oh, you can look in your little booklet. We did a series of experiments comparing. We're going to look at the viscosity at high and low shear using sickle cells and mixed with normal cells, and at varying oxygen tensions. So varying degrees of mixtures of AA and SS cells and varying degrees of oxygen tension. And what we show is that for high shear experiments at 150 inverse seconds or higher, there is in fact an optimal hematocrit right around 35, at which the hematocrit to viscosity ratio is at a maximum. However, for low shear, we cannot show an optimal hematocrit. That the hematocrit to viscosity ratio continues to deteriorate if we add more red cells, if we add more sickle cells, or if we deoxygenate the sickle cells. Consequently, our prediction is that at post-transfusion, arterial flow is going to follow the rules, but venous or microcirculatory flow may be negatively impacted by transfusion. Why did in the Icogen study, that where patients, if we just raise the hematocrit without altering the physical characteristics of the cells in a very substantial manner, patients may do worse. Oh, well, then we'll be finished on time. So, the studies I just described, they were done ex vivo. So we took blood from normals, we made these mixtures, we altered the oxygen saturation and so forth. Now we're going to look at the same experiments from blood in patients who are on chronic transfusion for stroke and the other indications. So these were 15 children in whom the transfusion of 2 units every 3 or 4 weeks is the standard treatment. So the hematocrits increased by 6%, the percent S went down by almost 6% on average in these 15 children. The post-transfusion, these slides I couldn't even get to go onto PowerPoint, so that is why we have just the words. So the post-transfusion whole blood viscosity, higher significantly than the pre-transfusion value. Simply adding red cells, oxygenated, increases the whole blood viscosity at both high and low shear. In fact, a 21% increase in hematocrit increased the viscosity by 34%, so a big effect at low shear. And the effect is even larger at low shear if you deoxygenate the samples. So our post-transfusion hematocrit to viscosity ratio at low shear, 1 inverse second, was decreased by almost 18%. So these data would predict that flow in the microcirculation in a convoluted and in a convoluted venous circulatory bed might be negatively impaired by transfusion. And we believe that the individual patient's native hematocrit may actually reflect the best balance between blood viscosity, oxygen transport, and blood pressure. So in conclusion, transfusion associated with considerable benefit in patients with sickle cell disease, but does carry these risks that we have to consider, and that prudence dictates that we carefully surveillance these patients for these issues so as to best manage them. I hope it didn't confuse you too much.